like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Tonight's topic is co-designing a flourishing future to benefit all. My co-host and moderator of the chat, Dr. Dan McCarter, is out tonight. He's not feeling well. He's feeling a bit under the weather. Dr. Dan, we hope that you feel better soon, and I can't wait to have you back on again. Our guest tonight is Dr. Rick Botelho. Dr. Botelho, welcome to the show.
Thank you very much. Pleasure to be here.
You know, I appreciate you coming to join us here, doing our kickoff episode for 2022. 2021 was quite a ride. It's unfortunate that we're having to deal with this Omicron just shortly right after Thanksgiving, hearing about this Omicron. I myself, my family, we spent the last 10 days being ill, started with our youngest, and then slowly everyone in the house getting, the upper respiratory like symptoms. We tested COVID negative twice. But I think if anything, with this particular wave, although it's very contagious, we're not seeing all the pneumonias and the complications that we were seeing with the Delta over the summer. So that's hopeful. Gives me some hope, at least going into 2022.
Let's hope so.
So Dr. Botelho, I would love to hear about your background, where you trained, and especially with your experience with NHS and how that sort of shaped your career with where you are now today.
Well, I went to Nottingham Medical School in the early 70s. It was a brand new medical school. And it was innovative, and that's the reason why I went there. And so a lot of the training was really person-centered. I mean, if I look at all the professors I had, it was really about the care of the patient without regard to, you didn't have to even think about the cost of care. And so that gave me an amazing grounding on how healthcare should be delivered, which is basically the ethos of ChenMed. I've long been a fan of it because I think, the intro, I think, sort of encapsulates what healthcare should be. And so I finished my training, did my vocational training in general practice in England. I worked in a suburban and in a rural practice while I was there. And I was very attracted to rural practice because for lots of different reasons. But I came over to the States that was back in 81, 82. And I went into a rural residency training program and worked there for 3 years before there was a hospital financial crisis, and they decided to close down the rural residency tract. And it speaks to the inequities in rural areas because they get a raw deal in this country. There's very little support. Anyway, so I went to University of Buffalo, and then I went to the University of Rochester. I was there for over 25 years. I was part of the residency training program, ran a fellowship program for education and research. And I've now moved down to Charlotte, where I'm 4 houses down from my grandson. And I'm now, yes, indeed. It's a real treat. And so, and I'm now working just 3 days a week in an integrative care practice. And I also actually last year I did something. I actually got trained and took the boards in lifestyle medicine.
Okay.
So I love learning, and so it's something that's never left me. But I think the imprinting experience of being in the National Health Service, and even when I was going through working in the residency training program, I was very fortunate to be at the University of Rochester because it was George Engel was there. He taught the biopsychosocial model. And the residency training program was very progressive. It was all about keeping people out of the hospital. And when
Wow.
I was there, I used to do everything. I used to go in the hospital, do delivery, all that stuff. And I didn't get paid for admitting patients to the hospital. I didn't get any extra money. So my incentive was to keep them out, because if I admitted them, it was more work when I was doing 2 weeks of on-call work. So sometimes I would go up to the emergency room and I would see the patients there, and I would override the ED physician's orders and say, this patient can go home. We can look after this patient at home. So my experience in England was very much, it's really ironic because, in general practice in the UK, you used to do telephone calls to patients. You used to do home visits at the end of the day. And, you come over here and of course, they talk about hospital care at home,
Yeah.
which is an oxymoron for me. So that just gives you a little bit of flavor of my different perspectives. But what I think it speaks to is the profound influence that you can have at the beginning of your career that can set you off in a much better trajectory. My concern is that the system is so transactional,
Yeah.
so RVU based. It's all about number crunching. These hospital systems regrettably have not woken up and seen the light of day, with things like direct primary care models. And it's antiquated and it needs to be disruptive. And I'm glad that ChenMed is one of many companies that's chipping away at a legacy system that is long overdue to be extinct.
Oh, gosh. Hopefully more sooner than later, because healthcare transformation really, it equals health equity. Because what we're seeing right now is the exact opposite of that. It's such a mess. It's a mess of a mix of systems. I don't think you have anything. Probably the closest thing we have here in the United States to the NHS, where the doctors are employed by the government, the patients don't see a bill, would probably be the VA.
Exactly.
Outside of that, it's just such a mixture. I mean, if you don't have health insurance, it could very well you could very well feel like the way many people do in third world countries, where there's no system at all in place. You just the entire brunt of the cost is on you, unless you're sick enough that you need to be admitted to, of course, to through the emergency room. Then the hospitals will admit you. At least they'll have that. But the system it's very complicated. It's very, very complicated. So tonight's episode is titled "Co-Designing a Flourishing Future for All." And if I remember correctly, this past year we networked and connected with a lot of people. And I want to say that you and I first connected on Clubhouse. I'm not exactly sure, but I think that's where we connected. And that's where I first started learning about the Equity Muse. If you could tell me a little bit about that journey.
Well, it's very interesting because what happened at the very beginning of the COVID crisis, I was just doing a locums job and I could read the writing on the wall because patient volume plummeted. Within a week, it went down to nothing. And so because I was doing a locum, I got basically 1 day's notice that I didn't need to work the following day.
Oh, my goodness.
Well, it was a blessing. It was a blessing because it gave me, I've been in academia and I've had the fortune of having sabbaticals. So I just took it as an unemployment sabbatical. The long and short of it was it took me out of the eye of the storm of the COVID crisis and looked at it from a sort of zoomed out and looked at the big picture. And I decided to coin this phrase, Equity Muse. And equity, unfortunately, has multiple meanings. And depending on whether you're talking to business people or health people, it's got at least 3 different meanings. There's the business meaning of it, there's the legal meaning of it, and then there's the health and educational aspects of it, or the social aspects of equity. So it's a confusing term, but the idea of a muse is a change agent, a particular type of change agent. And the purpose of change agents are to ask the right questions that inspire people to take effective action. So it's the power of questioning. And, I've put a link in there. Actually, I wrote a blog post. I did my inaugural newsletter, and I'm on my 3rd weekly one. And the one that I shared in the comments section here is basically looking at, how we need to launch Equity Moonshot. And what Equity Moonshot is basically it's reframing exactly what the title of this session is, which is how do we co-create an equitable, regenerative, and sustainable future. And I want to be very clear, it's in that order, because the problem with the COVID crisis, as you know, is that it just exploded awareness about inequities, lots of different inequities. It did such a good job of it that, we should take it as a learning opportunity, but I'm not optimistic that we're going to be able to do that good of a job of it. But the thing about this is it's all interconnected to other problems. We tend to focus in the health sector about health equity. Sure. And regrettably, equity is much bigger than in the healthcare system. And the determinants are beyond the social determinants of health. There's a great book by Daniel Dawes, who wrote a book about the political determinants of health, which is a fascinating read. But actually, I zoom out and talk about the ethical determinants of health, because it's all about the conflict we have between individual and social values, and how we navigate between, individual freedom on the one hand and social equity on the other. And that is being played out in spades at the moment with the whole COVID crisis about vaccination and wearing masks and whatever. And then you politicize it, and it just creates even worse political dysfunctional polarization, enhances trust, paranoia, etc. And it just makes mental health so much worse. And I'm seeing, as you are, we're seeing patients coming in who are just so distressed with the state affairs, not just the COVID, but the political climate we're living in as well.
Sure.
So.
Sure. There's definitely a sense of desperation. The politicians are noticing it as well. Now, when you never would have thought that in the greatest country in the world, that the number one cause of bankruptcy would be medical debt. And the tragedy is that more than half of these people who declared bankruptcy because of medical debt, they have insurance.
Exactly.
So even having health insurance doesn't protect you from bankruptcy.
Yeah.
So, I don't know any other developed country in the world that has millions of its people literally just one diagnosis away from financial ruin.
Yeah.
I mean, this is the state of affairs in the United States right now. And the health outcomes, our health outcomes don't compare with the other developed countries in the world. So you're right. There's a lot of politicization. There's a lot of misinformation. But sadly, what's happening is people are suffering, and actually now we even know they're going broke because of it.
Exactly. I mean, I think that's the real challenge. And in actual fact, back in the early 90s, I wrote an article. This was around the healthcare reform when Hillary tried to unfortunately, she made a number of serious mistakes. But nonetheless, it was a very noble effort to try and, expand healthcare coverage. But back then, I actually wrote an article about, it was entitled "Overcoming the Prejudice Against Having a National Healthcare System." And it got published in the annuals. And in it, I just provide a simple framework of what are, individual values versus social values. And, on the one hand, equality and equity, on the other hand, freedom and liberty. And so when you have that balance out of balance, what gets shortchanged? It's, equality and equity. And so this is such a deeply ingrained cultural issue that unless we begin to deconstruct how people think about the need for healthcare for all, it just gets mired down. And Obama did a superb job of getting through and expanding coverage, but it's falling back again. So these are deep-rooted problems, and I think sometimes we just take too much of a superficial approach to this without digging deeper into the deep root causes.
Yeah, unfortunately, this quickly voices start getting raised, and then suddenly places like England, they obviously must not believe in the free market, right? Mm. They obviously don't believe in liberty, right?
Well, no, it's funny. I'm not sure. I think it's just I think a better way of thinking about it is that the only differences between a liberal and a conservative mindset is, and there's a great book by Jonathan Haidt who wrote this book called The Self-Righteous Mind. I think you know it. But he says we've got the same values. The thing that differentiates us is the priority in our values.
Yeah.
And unless you can take a meta position to that and step back and say, okay, how can we sort of find, I talk about tripolarity stewardship, which is, and it goes beyond the notion of dysfunctional polarization and polarity management, because you need a third pole in there, which is what I would call the equanimity of equity. As long as you are willing to advocate for fairness. Now, if you want to advocate for unfairness, you have to give your rationale for saying why you want to have an unfair society. But we have to come up to an agreement about what's fairness. And we just don't have those debates about what fairness is. And if you work from a premise of maximizing fairness and also maximizing individual liberty, then you can perhaps find a middle way. But the problem is that we're not we're so stuck down in dysfunctional polarization at the moment.
Yeah.
We have to get back to the table and say, well, how can we find a middle ground? But in the current political climate, that's extremely difficult. So it's going to have to come from the public sector. It's going to have to come from people. The political system cannot fix itself. I don't see it fixing itself anytime soon, which means that people have to be sufficiently disgruntled and start saying we have to clear up this mess, because it is a huge mess.
I think one of the big drivers of this, especially for most of the people I know, most doctors and nurses who get into healthcare are good people who want to make a difference in people's lives.
Exactly.
I mean, we're driven by a high sense. We have a strong moral compass as we get into our careers and get into our professional lives. But when we start to see the inequities happen, and you see it in every step of the entire healthcare delivery system, you can't brush aside the things that make us feel morally uncomfortable. We cannot. I think that needs to be at the center of care delivery. One of the advantages of functioning in a fully capitated model is that we don't bill.
I know. That's a blessing.
And because if you're looking at, there's so much waste in the healthcare delivery system. If you look at, you can go through and you can tweak little bits of waste here and there. Maybe there's a couple too many of specialty referrals, or there's a couple too much of the overprescribing of the brand name drugs over generic equivalents when they're available. But really what's driving the waste in the country is all the unnecessary hospitalizations. And so if you invest properly in a true quality primary care delivery infrastructure, then suddenly you start to see all those unnecessary emergency room visits and hospitalizations, they start to go down. And then you're only profitable if you're effective. For us, we're profitable if we improve health. Like, if you're effective in healthcare delivery, that means that you are good at improving health. You're reducing unnecessary emergency room visits. You're reducing unnecessary hospitalizations. See, the bar is set so low and the costs are so high as soon as the patient steps foot in the emergency room, that right now, I mean, once you have the data, once you have the reporting, especially infrastructure in place, then your goal is to improve health rather than to bill more.
Exactly. That just resonates with my experience of when I was at the University of Rochester, and I said we didn't get paid for hospitalizations, we didn't get any extra money for it. So and if you have a choice of looking after somebody in the office and at home, you do it. And that was one thing about my training in England, is that we used to look after. When I came over here, first of all, I was amazed how low the threshold was admission to hospitals.
Oh yeah.
And if you give people the choice, they do not want to go into hospital. That's the last resort. And there are obvious cases where it's definitely needed. But
Sure.
when I first came over, it was my tolerance and acceptance of risk. I had to sort of lower it a bit because I was realizing that people had different thresholds, whereas I felt much more comfortable. But if you create a culture where that is the norm, then
Yes.
then it changes everything because people feel more comfortable. I can look after this patient at home.
Sure.
So,
Sure.
and of course, patients love it. And then you combine it with the fact, I mean, the great thing about the COVID issue, I'll give you one of the bugaboo I have. Okay. One of my bugaboos is the whole notion of virtual video visits versus telephone visits. And I worked in one setting where patients had the option and it was encouraged to do it. 95% of the people just wanted a phone visit. And and the thing about the video visits, they're much clunkier. There's more barriers. You have to set up a time and they have to be set up in a certain way. Whereas with a phone, you just call and you're talking to the patient and it's much more convenient. If you ask patients, they more often not prefer the phone to a video. Now there's times when you need a video and that's fine,
Sure.
but if you let the patient decide, my experience is 90% phone is fine. But in the system, what? The system gets reimbursed higher for virtual visits than they do to phone visits. And guess what happens? You get the admin breathing down your back saying, you've only got X percentage of your out of office visits are virtual. And, that just to me speaks to the perverse financial incentives.
Yeah.
So, I mean, that's one of my bugaboos. But on the other hand, when I shifted to this other environment where we could do phone visits, I mean, the way you can follow up with patients is so much easier. Following up with somebody who's depressed and you want to do a 2-week follow-up and you can go in and do something in 5-10 minutes and tweak something or whatever, and make adjustment or check side effects, yada, yada. And you can do it. And sometimes it takes longer. But if you pick the right medication and it's having an effect and you assess, then, you can do something so much more quickly by using a blend of those options. So, you just completely changed the paradigm. I know I'm already I'm talking to the converted who are already doing it.
Well, yeah, you can be effective in a lot of different ways. You don't have to be face to face with a patient to be effective with, say, influencing some preventive measure. I think about how much medical care we were able to provide while residents on the phone while we were on call in the hospital. How many patients who were admitted in the hospital were able to provide medical care just over the telephone? We're still effective.
Yeah,
You know,
absolutely. Yeah.
one of the advantages of a lot of advantages of full risk model, but one of them is that we're able to treat every single patient the same, regardless of their financial circumstances.
Mm-hmm.
So once you take that out,
Mm-hmm.
and really, our neighborhoods are some of the most underserved neighborhoods across the country. We have a center in St. Louis where more than 90% of the patients rely on us for transportation services. Just imagine. Okay, so imagine all the social issues that you're dealing with there.
Mm-hmm.
But and we guarantee every patient that we'll be available to every single one who needs medical attention, literally.
Mm-hmm.
And that's what happens when your approach to medical care is a moral one. And nobody should suffer because of an access issue.
Yeah. I just happened to notice somebody put a question in LinkedIn. I can't see the link. I don't know if your staff can put it in, but
Sure. Here, let's put it in here from Saria. So let's pull it in here. Pull it in. Do we got her in here?
Okay.
Okay, Dr. Botelho, thank you for your compassion for equity and career-long dedication to changing behaviors, especially with regards to your advocacy for tobacco cessation. Can you provide pragmatic ways to address inequity in healthcare from the exam room on a daily basis? What are some ways to address from the grassroots? Oftentimes, physicians are burnt out or experience moral injury due to a sense of futility. If we can do something, anything tomorrow, we can empower our colleagues and ourselves today.
Well, I think that question requires another session. It's a beautiful statement, and it can go off in many different directions. Um, I think the big issue, and I know many physicians working in the space of a physician burnout. And I'll give you just one example. I mean, we don't have time to go into that, but I went into one practice. This gives you the sense of pressure and demand on people. I went in this one, I'm sort of working different locations now. I'm just sort of doing locums. But anyway, I worked in this one session. And, I went up to the lead physician and I said, do you think it'd be possible for us to maybe get together for 15 minutes once a week just to have a sandwich or a coffee together? And you know what his answer was? I don't have time.
Oh,
So I said to him, I says, well, what if I came to you on a daily basis and said, 1 minute, can I have 1 minute of your time? And since that event, I've been doing this, and I'm doing this in my practice now with this physician who's working in integrative practice. We have 1 minute a day where we come up and we talk to each other about something interesting. I'll give you one little story, okay? He came up to me and said, I had this patient with Parkinson's disease. And by accident, the daughter gave her mother a hot sauce that was only meant to be sort of licked, but she took the whole thing in her mouth. And it just blew her mouth up. And half an hour later, her Parkinson's tremor improved markedly. And I thought, wow, what's that? So he started looking into capsaicin and various other things.
sure.
And interesting, I went to, I'm a great fan of nutrition facts. If you ever have a problem, you think, is nutrition help, whatever? Well, and looked at Parkinson's disease. And it talked about the use of red peppers and capsaicin for helping to reduce the severity of Parkinson's disease. Now, needless to say, there haven't been trials, but, those little things that happen in practice are gems. And if you don't have a sense of learning something on a regular basis and renewal, then you lose your you just get broken down by the drudgery of the treadmill. And that question requires, you need to ask her to come on and talk and respond to that question.
Yeah, we definitely.
Great question.
It's a challenge to address inequities in the exam room when when you have to factor in the cost of care delivery, and finding that balance. Like, what happens when you cannot afford what's evidence-based clinical guideline?
Yeah. I do have one actually, and I'm sure many people already are doing this, but I'm surprised that I come across physicians who don't do this. But there's two versions of GoodRx, and there are other apps, but I use the professional version. And before I prescribe something, I commonly just look in and say, what's the cheapest for this medication if they have to pay out of pocket? And there's huge variations. And not only that, the nice feature about it is you can go in, if you get the patient's telephone number, you can send the coupons directly to their phone. So that's a little tip. If you're not using it, it's a great one. You can save patients a lot of money.
Wow. Well, let's take a quick 20-second commercial break,
Okay.
and then we will come back and wrap up tonight's episode.
ChenMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chenmed.com/physicians for more information.
And we're back. Dr. Botelho, thank you so much for joining us again tonight. There's clearly, there probably has never been the level of burnout that many physicians are feeling today.
Yeah.
And especially from that sense of a lack, that loss of their purpose, their sense of purpose with why they got into medicine in the first place. Nobody got into medicine to spend hours a day with the charting and the documentation that's required just for reimbursement. So for those doctors who are experiencing burnout because of this, what are some suggestions for them to help overcome, especially when it concerns with all the stress that comes from the time that's spent on with the billing?
Yeah, it's a big question, and that's another episode too. I can certainly give you in touch with somebody who's good at talking about this on physician burnout. There isn't a quick, as you know, there isn't a quick fix. I
Yeah.
think there's lots of little things that you can do for yourself, like the 1 minute thing I talked about with you.
Yeah.
Um, taking, I'll give you a strategy that I'm using. I didn't used to use this, but I'm using it much more frequently because I just noticed that, people are coming in and their anxiety levels and distress levels are higher. And I'll just give you this an example. And I go through this very quickly. And I said, I'm going to ask you a question. You probably haven't been asked this question before, but are you aware of the muscle tension in your body right this minute? And invariably, people's shoulders are up a little bit, and they sometimes drop the shoulder. I mean, you can see people coming in; they're hunched or over, or they're holding on to their arms. Their anxiety level increases the muscular tension.
The fist.
Yeah, the fist as well, or holding onto the arm or whatever.
Yeah.
And just paying attention to but also on yourself. I mean, I had one woman recently who was so emotionally angst. It was just, extreme anxiety. And, I said to her, I says, just try and do, a series of slow, deep breathing exercises, sleep inductions, breathe in slowly, out, hold, and whatever, there's different techniques. But I said, before doing it, pay attention to your muscular tension in your body. You can do this while you're at work. Loosen it up a little bit. Take one deep breath and go through the cycle. Empty your mind, because it's good to give your brain a rest. And I said to her, try and do that every hour throughout the day, and do the deep breathing exercise before you go to bed, even if you know you're going to fall asleep. And if you wake up in the middle of the night, do it again. So there's lots of little, tips that, can be beneficial to our patients, but also to our staff as well. And I think a lot of healthcare systems are paying attention to this, because they're suffering, because if they have a high attrition rate, it's like 20% attrition of healthcare workers since the beginning of COVID. And then you take in the number of sick. I mean, the systems are really under incredible stress. So there isn't a quick fix, but I can give you a suggestion for somebody you can invite onto your show later on about physician burnout. So,
Well, Dr. Botelho, thank you so much for joining us tonight. I look forward to bringing you back on again. With Drew and Jess, if we can share Dr. Botelho's information to get connected with the Equity Muse and his newsletter, I would love for that to happen with the audience. Thank you so much for joining us tonight.
Well, thank you very much. And as you can tell, I even though I'm at the end of my career, I still enjoy seeing patients, and I enjoy learning. And that is important to preserve. And it's unfortunately easily lost. So hopefully I might inspire a few people as an Equity Muse to think more broadly about the social determinants of health, because we have to go upstream beyond the political to the ethical. And that's where the real work needs to be done. So if you want to do some deep thinking, read I don't give you answers. I just ask you difficult questions. And that's what we need to discuss those difficult questions if we're going to change things. So.
Absolutely. Well, thank you so much for joining us tonight. For more information about tonight's topic and to explore career opportunities with ChenMed, please visit chenmed.com. We believe access to primary care is a right, not a privilege.